Hello everybody and welcome to our module on hyperlipidemia. Shown on the screen are the four measurements that are routinely obtained in the clinical setting to assess a patient's lipid status. We routinely measure patients' total cholesterol. We measure their LDL-C cholesterol. This is the level of cholesterol associated with LDL particles. You'll hear people refer to a high LDL level or a low LDL level, but actually we don't routinely measure the number of LDL particles. Instead, what we measure is the amount of cholesterol associated with LDL particles. We also measure the amount of cholesterol associated with HDL particles, and then finally we measure the amount of triglycerides. And from the video on lipid metabolism, you may know that there are other lipid particles like VLDL and chylomicrons, but those are not routinely measured. These are the four routine measurements that are obtained in the clinical setting. Now, another thing you should know is that we don't often measure directly the LDL cholesterol. Instead, we often calculate it, and we calculate it from something called the Friedewald formula. The Friedewald formula says that the LDL cholesterol is equal to the total cholesterol minus HDL cholesterol minus triglycerides over 5. And as long as the triglyceride level is relatively normal, this formula is accurate. And because your triglyceride level rises after you eat a meal, this is one of the reasons we ask patients to fast before they have their LDL cholesterol tested. When they're fasting, the triglyceride level will be very low, and this formula will be accurate to calculate the LDL cholesterol level. When we say that a patient has hyperlipidemia, we usually mean that they have either elevated total cholesterol, LDL cholesterol, or triglycerides, or potentially all three. And the reason we're concerned when patients have elevated levels of these plasma lipids is because they've been shown to be a risk factor for coronary disease and stroke. And in fact, hyperlipidemia is considered a modifiable risk factor because many times it's related to lifestyle factors. Modifiable risk factors for cardiovascular disease include things like smoking and obesity and also hyperlipidemia. One of the reasons many patients have hyperlipidemia is because they lead a sedentary lifestyle, they eat lots of saturated and trans fatty acid foods, and they have a lack of fiber in their diet. And all these things can contribute to high levels of plasma lipids. Most of the patients you'll see in clinical practice who have hyperlipidemia have a primary hyperlipidemia related to their genetics or their lifestyle, like we talked about on the last slide. But you should remember that there are some causes of secondary hyperlipidemia. There are lots of these, but I've listed some of them that are worth knowing, especially for step 1 on this slide. Patients who have the nephrotic syndrome develop hyperlipidemia. It's one of the components of the nephrotic syndrome. They typically have elevated LDL levels. Patients who are alcoholics often have high triglyceride levels. It's normal for lipid levels to increase during pregnancy. Usually the triglycerides increase much more than the total cholesterol, but both will go up. And then finally, there are two drugs that can raise your lipid levels very modestly. Beta blockers can raise the triglyceride levels, and hydrochlorothiazide can raise the levels of total cholesterol, LDL, and triglycerides. The amount that the lipid levels increase from both of these drug classes is relatively modest, and we usually don't worry about this clinically. But for step 1, they like you to know that the lipids can increase among patients who take these medications. Usually hyperlipidemia has no signs or symptoms. It's often called one of the silent killers along with hypertension. However, you do sometimes see physical findings in patients who have very markedly elevated lipids. These are usually patients who have one of the familial syndromes we'll talk about later in this module. Their cholesterol levels or triglyceride levels can get very, very high, and this can result in physical exam findings. Some of the signs of marked hyperlipidemia include xanthomas. Xanthomas are plaques that you can see on the skin, and they're made up of lipid-laden histiocytes. Histiocytes are macrophages, and they fill up with lipids and form xanthomas. These will appear as bumps on the skin, often on the eyelids. This is a picture of a patient who has xanthomas on the eyelids, and this is the picture of a child who has a xanthoma on the forearm. Sometimes xanthomas occur over the Achilles tendon in the leg. These are called tendinous xanthomas, and that's another classic finding of hyperlipidemia. And then finally, on fundoscopic exam of the eye, you can sometimes see a finding called a corneal arcus. These are lipid deposits in the cornea. If you Google this, you can see lots of pictures of what a corneal arcus looks like on fundoscopy. Sometimes patients who have markedly elevated lipids develop pancreatitis. This occurs when the triglyceride level gets too high. A normal triglyceride level is less than 150. The triglycerides have to get markedly elevated, usually over 1,000, to cause acute pancreatitis. The exact mechanism of pancreatitis in hypertriglyceridemia is unclear, but there is evidence that it may involve chylomicrons in the plasma. Recall that chylomicrons are formed after you eat a meal, and then they usually clear a few hours later, and they're very large particles. They are the largest lipoprotein particles. When your triglycerides are over 1,000, chylomicrons are always present, and these may obstruct capillaries in the pancreas, leading to ischemia. The ischemia and the vessel damage may expose triglycerides to pancreatic lipases. This can break down the triglycerides and release free fatty acids, and it's actually the acids that may be the problem. They may lead to tissue injury and cause pancreatitis, and this is one of the hypothesized mechanisms by which you get pancreatitis when your triglycerides are markedly elevated. For the remainder of this module, I will talk about the familial dyslipidemia syndromes. These are very rare genetic syndromes that result in markedly elevated levels of plasma lipoproteins. And the first familial dyslipidemia is called a type 1 dyslipidemia, and it's also called hyperchylomicronemia because, as we will see, the chylomicrons are markedly elevated. This is an autosomal recessive condition, and children born with this condition have very, very high triglycerides. Remember before I said a normal triglyceride level is less than 150. These people typically have levels that are greater than 1,000. They can have a milky appearance to their plasma when you draw blood from them, and as I said before, the chylomicron levels are markedly increased. The reason this disorder usually occurs is because there is a severe deficiency in the enzyme lipoprotein lipase. I talk about lipoprotein lipase in the module on lipid metabolism, but recall that its purpose is to remove triglycerides from chylomicrons. So if it is not working, the triglycerides cannot be removed and the chylomicrons will stay very large and full of triglycerides. This can happen either because people are born with a deficiency in the enzyme itself or because they are deficient in the cofactor apolipoprotein C2. Recall that C2 is necessary to activate lipoprotein lipase. So if either of these things are abnormal, you can develop a type 1 familial dyslipidemia. The main symptomatic problem in these patients is recurrent pancreatitis. As I told you before, when your triglyceride levels get this high, you can develop pancreatitis, and people with hyperchylomicronemia get recurrent bouts of pancreatitis. They can also have an enlarged liver and they can develop xanthomas. The treatment is to eat a very fat-restricted diet. There are reports of people with this condition having a normal lifespan with no apparent increased risk in atherosclerosis if they're able to adhere to the low-fat diet. A type 2 familial dyslipidemia is called familial hypercholesterolemia, and the problem in this condition is that the total cholesterol and LDL cholesterol levels get very high. This is an autosomal dominant condition, and there are relatively few autosomal dominant conditions, so when you come across one, you should take note, and this is one of them. The problem in this dyslipidemia is that these patients have few or zero LDL receptors. As a result, they cannot clear LDL from the plasma. This means their LDL will get very high. It can be over 300 if they are heterozygous for the gene mutation for this condition. It can be over 700, which is very, very high if they are homozygous. The main problem that's going to happen when the LDL is this high is severe atherosclerosis, and people with this dyslipidemia can have heart attacks in their 20s, which is very, very young. They also sometimes develop tendon xanthomas and also corneal arcus on fundoscopic exam. A type 3 familial dyslipidemia is called familial dysbeta-lipoproteinemia, and people with this condition have the ApoE2 subtype of ApoE. In the module on lipid metabolism, I talked about how ApoE is necessary for the clearance of particles like chylomicrons and VLDL particles from the plasma. People who have the ApoE2 subtype have lipid particles that are poorly cleared by the liver. As a result, they accumulate chylomicron remnants and VLDL particles, and these are collectively known as the beta lipoproteins. That's why this is called dysbeta-lipoproteinemia. Clinically, what this means is that these patients have elevated total cholesterol and triglyceride levels. It can be relatively mild with the total cholesterol greater than 300, which is increased but not as high as in some other disorders. These patients sometimes develop xanthomas, but the major problem is that they can have premature coronary disease if they don't get their cholesterol levels treated. A word on ApoE and the risk of developing Alzheimer's disease. If you happen to have the ApoE2 allele, there are data that you are at decreased risk for the development of Alzheimer's. On the other hand, if you happen to have the ApoE4 subtype, there are data that you are at increased risk of Alzheimer's. I talk about this in more detail in the neurology modules on dementia, but I just want to review this here while we're talking about ApoE2 and lipoproteins. The last familial disorder is a type 4. This is also called hypertriglyceridemia. This is also an autosomal dominant condition, and the problem in people with a type 4 disorder is that they have too much VLDL in the plasma. This may be because VLDL is overproduced, or it may be because it's not broken down appropriately, or it may be for both reasons. But whatever the mechanism, the VLDL level is too high, and what you see on blood work is that the triglyceride level will be elevated, usually in the 200 to 500 range. This is not as high as in some of the other disorders, so you usually don't see pancreatitis in a type 4 dyslipidemia. This type of dyslipidemia is associated with diabetes type 2. Most of these patients have diabetes. Most of them are also obese. Often this is diagnosed on routine screening blood work when it shows that the triglyceride levels are elevated among a diabetic patient. And the main problem here is that if the triglyceride levels are routinely allowed to be this high, these patients have an increased risk of coronary disease and they can develop premature coronary disease. And that concludes our module on hyperlipidemia.